This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 12, Disorders of the Peripheral Nervous System. Key concepts. Upon completion of this chapter, you'll understand that the peripheral nervous system disorders do not usually present as emergencies, how progression of acute disorders or exacerbation of chronic ones may lead to airway and breathing difficulties, why attention to comfort is an essential component of care for patients with peripheral nervous system disorders. Chief concern. The central nervous system and the peripheral nervous system are distinct as far as from the anatomical standpoint, but their functional standpoint gets kind of blurry sometimes. The peripheral nervous system disorders manifest peripherally, like sensory deficits, motor deficits, and then movement disorders. The peripheral nervous system. Millions of nerves control the body operations, receive the sensory input. They adjust internal functions and external stimuli, maintain the body's balance, originate in the brain or spinal cord, and reach out to the body. And this is nerve anatomy. So this is the nerve body, somal body. And these are the myelinated sheaths. Now, myelinated sheaths allow for something called pond skipping, so that the stimulus travels quite quickly. And then these are the axon ends or axon terminals, and generally our target organ is right here so that the neurotransmitter can get released into it. We'll talk about that a little bit more. So this is the axon. These are dendrites, somal body, and then synaptic terminals or axon terminals here. This is the business end, neurotransmitters that transmit to the receptors on the postsynaptic membrane. And what this is the target organ or the informational junction that it'll be passing information onto. So the neurostimulus comes down, and through exocytosis we have a release of the neurotransmitter. The neurotransmitter activates the postsynaptic neuron, and then sodium-potassium pump would initiate action potential in the tissue or information given or whatever the tissue's target response should be. And this is the neuromuscular junction, so same somal body, dendrites, axon, and this is a synaptic end. This is acetylcholine, ACH. So acetylcholine essentially through exocytosis is transferred into the sacrolamina or the business end of the muscle, and then the muscle gets told to initiate its contraction or shorten or function, whatever the stimulus might be. Functional divisions. Nervous system functional divisions are the somatic nervous system and the autonomic nervous system. In the somatic nervous system, we have the skin, the musculoskeletal system, and the voluntary bodily actions. And these contain three types of neurons: motor, sensory, and interneurons, organized into pair of nerve roots. In the autonomic nervous system, they pretty much communicate with organs and blood vessels and the body's automatic functions, subdivided into two sections: the sympathetic and the parasympathetic nervous systems. And these are kind of the balancing act of the body. So what one does to stimulate or bring about something, fight or flight, the parasympathetic nervous system, if increased, would do the opposite. And this is the autonomic nervous system, sympathetic versus parasympathetic. Please go over these and take a look. For every organ, there's a stimulator. there's an equal and opposite reaction through the parasympathetic nervous system. Example of this, the sympathetic nervous system in the lungs case causes bronchial dilation. And now in the parasympathetic nervous system in the lungs case, it would cause bronchial constriction. So essentially a balancing act. If one does one thing, the other one counteracts it. Nerve maps. Surface dermatomes, and this is figure 12.7 in your book, maps the body surface in relation to spinal nerves that receive sensory information from that area. Figure 12.8, which is here. These are peripheral nerve maps, and they describe territories of peripheral nerves that form in the nerve plexus supplying the extremity. So, the example of this, medullary plantar, would be on a nerve plexus. That, the whole yellow here, and here, and here. So, same way with the dermatomes. So, if you have a damage at about T10, this whole area will lose motor function and sensory function to it. So we may have numbness and tingling and decreased sensation in that area. Now, one or two things can be achieved from this nerve maps. One is if someone has trauma, we can definitely see where the possible damage might be. The other thing that we can see is if they're having motor neural deficits from peripheral nervous system dysfunction, like unmyelination of the nerve endings, inability to communicate, slowing nerve conduction, we're also going to get paralysis and maybe tingling, pain sensation, and so on in these areas. Pathophysiology of peripheral nervous system disorders. Now, we're going to talk about generally over these. Please go over these diseases in your book. Generalized disorders of the peripheral nervous system. Signal transmission is delayed or lost, and examples of these. Complex regional pain syndrome. We're going to talk about each one here as we kind of go down them. Produces severe and intense burning pain in an extremity. Exact pathology on this is unfortunately unknown. Allodynia and hyperalgesia, hyperalgesia, presence of pain from a non-painful stimuli or pain out of proportion for the stimuli. So you touch them and it's painful would be an example of this. So Guillain-Barré syndrome, autoimmune disorder. The body's immune system is triggered to attack the myelin sheaths in the peripheral motor nerve fibers, causing significantly slow nerve conduction. Cause is believed to be preceding viral illness. Some bacteria have also been associated with this. Multiple sclerosis involves the destruction of nerve myelin sheaths, and it's an inflammatory disorder thought to be triggered by viral or environmental causes. Check these off here. Poliomyelitis, viral condition, produces widespread destruction of motor neurons and can lead to total paralysis. Post-polio syndrome, this can occur up to 30 years after the initial infection, involves the loss of the patient's surviving motor neurons. Amyotrophic lateral sclerosis, or Lou Gehrig's, motor degenerative disease, made famous by the baseball player Lou Gehrig, affects motor function and balance, creates cranial nerve dysfunction, eventually causes dementia from destruction of frontal lobe neurons in the brain. Myasthenia gravis, an autoimmune disease, affects the neuromuscular junction, causes muscle fatigue with repetitive use, myasthenic crisis, profound motor weakness, and that would be systemic. Parkinson's disease is the next one. Movement disorder, and produces muscle rigidity, slow movements, and classic motor findings on physical examination. Cogwheel rigidity, spasticity, develops due to a lack of dopamine in the brain. Huntington's disease, genetic movement disorder, involves bizarre, uncontrolled movements and progressive dementia. Occurs due to a loss of neurons in the brain that help control motion by inhibiting motor signals from the brain. So that covers all of our pathophysiology. So please look over those. Those are the ones that we'll see the most and will be formulated in test questions. History. History of present illness narrows down to the most significant concern. Develop a timeline And please use the acronym OPQRST-ASPN. Onset provokes quality, radiation severity, and time, associated symptoms, pertinent negatives. This will help you narrow down even more most pertinent history. Correlative sensory symptoms, dermatome and peripheral nerve maps need to figure out if they're having motor neural problems, where it is, where's the approximate line, what time it began, so that you can be a good historian. Past medical, surgical, family, and social history. Focus on neurological and related items. Past medical events like stroke, disease, trauma. If they've had hypertension, diabetes, renal disease, and so on. Determine if the past conditions run in the family. If in the social history, as far as that goes, ask if they use tobacco, alcohol, or drug use. Or if they have some sort of occupational exposure, even. Examination ranges are limited to whatever the patient is complaining of at that time to a complete neurological system examination. Other systems to examine may be the cardiovascular and muscular systems. From a neurological standpoint, the patient should be examined for sensation in all extremities as well as the trunk if extremity sensory deficits are found. Area of sensory deficits may point towards either peripheral nerve problem or spinal nerve problem. If a dermatome distribution or a situation not related to a specific nerve distribution. So if we find something in the dermatome assessment, we should definitely identify that. Muscular strength and equality is examined both distally and proximally and compared on both left and right sides, upper and lower extremities. Circulatory standpoint. Assess the peripheral pulses for strength and equality and the heart for new murmurs if they might have them and regularity of rhythm. Also palpate the abdomen for any kind of pulsatile masses that might indicate an abdominal aneurysm. Assessment. Neurological conditions. They may have a subtle onset, classic pattern that suggests a particular condition, like say Parkinson's or progressive paralysis. Guillain-Barré is one of them that gives us progressive paralysis that starts in the legs and it moves towards the arms and torso. It's a key to narrowing the diagnosis. The better historian we are, the better treatment the patient gets. Detailing history as much as reasonably possible whenever coming across that. As far as treatment goes, peripheral neurological disorders, many are chronic. Paramedics need to offer comfort and transport. They may just need supplemental fluids, but in addition to that, if they're having a crisis from their chronic disease, the exacerbation of complication of chronic disease, the paramedic may need to intervene on this. An example of this would be patient's respiratory drive or respiratory effort. If it's inadequate, you're going to have to facilitate an airway and support with positive pressure ventilations, whether it be by simple BVM and BLS methods or full-blown intubation. As far as evaluation, monitoring performed during transport depends on the chief concern and condition. The critically ill, please intensively monitor them every 2 to 5 minutes. Isolate peripheral neuropathy if they're just having it in one isolated location. Repeated vital signs and neurological checks to see if it's progressing. As far as the disposition goes, stable and chronic conditions can be managed by any emergency department. Critically ill patients should be brought to the closest emergency department for evaluation and stabilization. In conclusion, some neuromuscular diseases impair the patient's ability to adequately breathe and may require intervention by the paramedic to prevent hypoxemia and hypercarbia. The paramedic may be the first healthcare provider that the patient with new onset neuromuscular disorder encounters, who has the ability to positively impact the patient's medical care. References for this chapter were taken from Professional Paramedic Volume 2, Medical Emergencies of Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandcc.edu or 405-219-7613. Thank you.